Thank you very much. I want to thank the organizers for allowing me to present here and make a case for drug salvage in relapse and refractory multiple myeloma. It's a daunting task, specifically because there is no data, and my opponent, which is my very good friend, Susan Lynch, has the advantage of embarrassment of riches with also many new options and all these triplets. But we all agree that once treatment fails, particularly when proteasome inhibitors and immunomodulators fail, the prognosis is very poor. And it's not the same approach for those patients who have already relapsed from the two core drugs. The disease-free survival is 4 months, and the overall survival is less than a year. So that's a group of patients that is quite challenging and daunting in our clinic. So our challenge for today is that there is no data of phase 2 trials for 4 drug regimens. There is certainly not phase 3 trials, and there is only a case for hypothesis. So this is the way I was left when I was asked to participate in this debate. If you look at the landscape in myeloma, certainly there is expected to get results from triplets and quadruplets frontline, but we don't have any trial ongoing, even to look at 4 drugs, even in the relapse refractory setting. But what is clear in cancer biology in general, and you can use a model of lymphoma or other neoplasms, is that since there is certainly clonal heterogeneity and there is a high level of mutations through the evolution of the disease, as was presented by Dr. Richardson earlier this morning, it is imperative that we take advantage of synergy among agents and try to make emphasis in non-cross resistance and try to cover as much as possible the variability of that clonal heterogeneity, either in the induction phases or also in the relapse setting where there is much more variation among the clones. So I think I have made the point that clonal heterogeneity and clonal tides are the basic biology to confirm that we need continued therapy and combination of therapies, and that the therapy should be non-cross resistance, that we should avoid additive and overlapping toxicity to maintain that quality of life that was mentioned, and that we should capitalize on the increase in additive effect or the synergy effect among those agents. That has been already expressed by Dr. Lynch, who's taking me for a ride in this argument. So triplets certainly do better in the front line. And as you can see here, the overall response rates improves as you capitalize on this non-cross resistance and additive and synergic effect of those drugs. And certainly the most successful combination is the proteasome inhibitor with the immunomodulator, and now the corticosteroid. You can also incorporate alkylating agents, and maybe even the second-tier effect of drugs that facilitate the effect of these core drugs, such as HDAC inhibitors. Just to also make the point that the phase 2 randomized trial called Evolution in the frontline did prove that not always when you add the 4th drug, you're going to have better results. For instance, here they tried the combination of VDR or the VRD, the typical CyBorD in 2 different type of schedules, and the combination of alkylate or cyclophosphamide with bortezomib and lenalidomide. And as you can see, the winner was the triplet with a modified intensity of cyclophosphamide, but did not, certainly the quadruplet was underperformed, particularly because of the overlapping toxicity. If you have an alkylator that's going to cause you myelosuppression, that will limit your ability to give immunomodulators at a proper dose. And therefore, it is important to know when you're using combination of drugs, it's best to use non-overlapping toxicities. This schema tells you whatever is available for relapse and refractory disease. And again, you don't see any quadruplets here, but you do see that the field is moving to combinations with triplets, and also incorporating immunotherapy and targeted therapy with venetoclax, such as was already mentioned. And if you can look at this busy slide, the ones that are more powerful are those triplets that include a monoclonal antibody, again, capitalizing in the lack of a non-overlapping toxicity. So in which patients are we going to use the quadruplet? I have to convince you today that there should be a place for that quadruplet. So let's look at this case. 72-year-old gentleman with a history of stage 1 colon cancer, treated in 2013 without any recurrence, without any problem. He had also high-grade transitional cell carcinoma, treated and maintained without any problems. And he had other comorbidities, but actually he had a very good performance status. And he had a family history of myeloma. His brother died actually at age 74 of myeloma. He was also my patient, and had other morbidities. So we started with bortezomib and dexamethasone. I think in the morning Dr. Lenz showed that sometimes in the elderly with so many comorbidities, you can do duplets with the same outcomes as the triplets. So in this case, we did Bortez-Dex, then we did Cyborg-D with an excellent response, but it had to be discontinued due to neuropathy, even though we did it weekly and even we did it subcutaneously. The following relapse, the patient received ELO-RD, who only lasted about 6 months, and then we moved into KPD as the best salvage available during that time. And it had a very good result and for very good time. Then later, the relapse was treated with daratumumab, a single agent with a very good response. So here we have the serum protein electrophoresis and the immunofixation of the presentation. As you see, first an IgG kappa that upon relapse completely disappear. And as you can see, the therapy eliminated all the clones reported as IgG kappa. But upon relapse in February 2017, you see that the serum protein electrophoresis had no more signal of a monoclonal protein, but everything was noted as a shift with free light chains in the serum and in the urine. So these particular patients who escape with light chain disease are particularly challenging. So the patient had a very, what we call a light chain escape. And together with that, he had abdominal pain. We found several masses in the abdomen with ascites and visceral involvement, and a mass extruding into the abdominal wall, causing these abnormalities, as you can see in the physical exam. The ascites was obtained, and it was involved by myeloma, as you can see here. The cells actually had a very high proliferation rate at that time. So I would like to ask you if you can raise your hand, which would be your best next treatment? Would be DARA KPD, DARA Cyborg-D, DCEP, or any other combination of DCEP, like VDT PACE, or DCEP thalidomide, or DCEP Revlimid. So who votes for A? One person. Who Who votes for Dara-Cybordy? Nobody. Who votes for DSEP? 2 persons. And who votes for VDT-PACE, DSEP-THAL, or DSEP-Revlimid? Well, I guess the rest, everybody, because nobody voted for anything. So I guess we're going to have to ask for hospice for this patient. The patient had actually good performance status, even though he had that abnormality. We actually elected to do infusional therapy, and we did DSEP. And so what is available for DSEP chemotherapy as data? And we have this paper from the group in Moffitt, in which they compare in a retrospective fashion different infusional chemotherapies. And so you would think that more is better. Here they compare VDT-PACE versus DSEP versus hyper-CVAD in these different regimens. An example, hyper-CVAD is with vincristine, that we all know that has really no activity against myeloma, but it was used in the past, so they had that data available. The patients who were refractory to both lenalidomide and bortezomib were similar in both groups. And if you look at the progression-free survival in the three regimens, is exactly the same. So for these patients who have very active disease with extramedullary disease, none of the combinations appears to be superior to DSEP. So here it proves that even by overall survival, doing more for this patient will only add toxicity. We also have information from the group of Australia, in which similar analysis was done, particularly using DSEP as a pre-induction before transplant. This is a regimen used as Salvage. And as you can see, the responses when you combine DSEP with DSEP thalidomide or DSEP lenalidomide or DSEP with thalidomide and bortezomib give you exactly the same results in terms of survival. The only thing that made the difference is that after inducing a response with this quadruplet, if you breach into transplant, you can shift the curve for progression of free survival to the right. So if you're going to use any of these quadruplets as salvage, always try to consider the stem cells that you harvested before to salvage the patients. And that's a very common practice that we have. Now, almost all our patients get stem cells harvested, and then we can use the stem cell transplant in salvage both for cytoreduce, consolidate response, and more importantly, to recapitulate the hemopoiesis that happens in these very multi-treated patients who are already pancytopenic, thus allowing us to use research and phase 1, phase 2 trials later on. So now the use of salvage autologous transplant is also something that should be considered. So this is what happened to the patient after the infusional therapy and consolidation with alkylating agents. He had a response and a progression-free survival of about a year before he. Certainly, we are moving to the future in which we will incorporate novel agents into these triplets and quadruplets to try to capitalize on the response. Again, no much data, but we do have this combination of bortezomib, thalidomide, and dexamethasone in combination with the HDAC inhibitor panovinostat. And in a phase 1, phase 2 trial, it was published in Lancet by the British group. And as you can see, patients who have more than two more lines of therapy had very good response with an overall response rate of 75% and a VGPR of 13%, offering a progression-free survival using this combination of about 9 months to 10 months. The United States, the group of Hackensack had similar approach, combining carfilzomib, lenalidomide, vorinostat, and dexamethasone. And in this group of patients who have very high risk and multi-treated, 100% had prior transplant, more than 90% had both bortezomib and lenalidomide, and more than 3/4 of the patients had had prior VRD, or a third were completely refractory to triplet. In this phase 1, they combined carfilzomib with lenalidomide in a phase 1 fashion, increasing the doses of carfilzomib, lenalidomide, and vorinostat, as you say, maintaining the dexamethasone in a constant dosing. And the combination was well tolerated with some toxicities, particularly hematological toxicities and GI toxicities. But the patients responded well and offered a progression-free survival of 12 months. So using this quadruplet, we could exceed whatever was expected in this very aggressive type of patients. U.S. Oncology has reported in the last ASH the combination of Cyborg-D plus daratumumab, and doesn't offer information about the results of this combination, but I'm sure that by the next meeting we will have an update with the results and progression-free survival. Suffice to say that the combination of Cytoxan, Dex, Bortes, and Dara was well tolerated with the toxicity indicated in the. So as my last slide and concluding slide, trying to tackle this question on this debate whether quadruplets would be standard of care in these patients, I would say that DCEP is similar to Hypersiva, Dorvidity, PACE in this very aggressive group of patients. So you can use infusional chemotherapy, but always thinking that it's best to follow by a consolidation or bridge to transplant. That the future regimens are coming, just as VRD, KRD, and KPD with DARA. I think those are the best performing combinations, and the results of that. I think we have to avoid overlapping toxicities. There's been improvement in adjunctive therapy, and you have to continue improvement in that aspect, particularly antibiotics, antiviral therapy. We are commonly using IVIG monthly for those patients who are receiving monoclonal antibodies and combination chemotherapy, and always considering stem cell transplant as a salvage also as an option. These are all my collaborators in the Myeloma Center. We're moving into 61st Street and York, and we're very excited about that move. And you have my email for my first slides available should you require any consultations or if you want to collaborate in any matter.